there's not necessarily a one-size-fits-all approach to treating CLL. So how do you decide which treatment is right for a patient?
So I always look at their underlying disease biology. So there's a couple really important tests that I send for all of my CLL patients by the time that they need therapy. So the first is to see what their underlying cytogenetics and molecular findings are. So there are certain good findings and then certain bad findings. One of the bad findings is having a deletion in the 17th chromosome in the short arm of that chromosome. The chromosomes are the big pieces of DNA within everyone's cells, and there's findings that are common in CLL. So a 17p deletion is a poor prognostic feature. And then there's a separate test where we can actually identify mutations in a gene called TP53, and these behave largely the same as a 17p deletion. So I always check for both. It's two different tests. Oftentimes patients have actually both of these findings, a 17p deletion and a TP53 mutation, but sometimes you can have the mutation without the deletion and vice versa. So that is one finding that's important when talking about different therapies. The other really important prognostic test is the Ighv mutation status. So this is another specialized sequencing test. It looks to see if the patient's heavy chain of their immunoglobulin protein has undergone something called somatic hypermutation or not. It's actually good to be mutated. What we know about people who are mutated is that they typically have better responses to most therapies, and their disease typically is one that grows slower. So I use those factors, and then I have a conversation with the patient. The two main treatment classes that I spoke about. So the Btk inhibitors, those work actually really well, and even the people with these really bad prognostic features. And so people with the 17p deletion, the TP53 mutation, they can have disease control for 6+ years on a Btk inhibitor, which is really good. And that was not the case a decade ago when we didn't have these drugs. Right. So that's something that's been hugely beneficial for our patients. The Venetoclax obinutuzumab regimen, that still works when people have the 17p or TP53, but it probably doesn't work as well. And so I had mentioned the median time for disease to come back hadn't been reached yet. It had been reached for that poor risk subset. And so the expectation for people with that poor risk marker is that the median PFS, progression-free survival. So again, when after someone starts therapy, when the disease then progresses, is 49 months. So, it kind of gives me a rough estimate of, gosh, these are your therapy options. And then based on your underlying biologic factors unique to your disease, this is what you can expect out of therapy A or therapy B. The mutated or unmutated Ighv, similarly, those Btk inhibitors work extremely well, even in people with the bad unmutated finding. So I think those are always an option. I think the other treatment is an option, but the people with that bad finding do have a shorter time until they progress of just under 5 years.